Hello, I'm Ann O'Day from the University of Kansas Cancer Center, and I have the pleasure today of moderating our tumor board. And I'm going to ask our esteemed panelists if they wouldn't mind going ahead and introducing themselves. We'll start out with Dr. O'Shaughnessy.
Hi everyone. Joyce O'Shaughnessy. I'm in Baylor University Medical Center, Texas Oncology, and U.S. Oncology in Dallas, Texas, and I'm a breast medical oncologist. Very nice to be here with you today.
I am Dr. Frank Piccini, radiation oncologist with GenesisCare in Michigan.
Hi, I'm Norman Woolmark. I'm professor of surgery at the University of Pittsburgh. I'm chairman of the NSABP Foundation and co-principal PI of NRG Oncology.
I'm Maxine Jockelson, and I am a professor of radiology at Memorial Sloan Kettering Cancer Center, where I direct the imaging for the Breast and Imaging Center. I'm primarily a breast imager with a little sideshow of doing PET scanning as well.
Our next patient is a 65-year-old Caucasian female with a right clinical T1C and 0 invasive ductal carcinoma, grade 2, ERPR positive and HER2 negative. She's status post right radioactive seed localized lumpectomy and a failed sentinel lymph node mapping with dual tracers, both methylene blue and technetium-99. So the question being raised is, given the sort of failed initial sentinel lymph node mapping, would administration of high-dose lymphoscintigraphy followed by another attempt at sentinel lymph node biopsy be something that's feasible to avoid the potential morbidity associated with axillary lymph node dissection, which is historically the standard practice in this particular situation? So we have some imaging findings here. Dr. Jockelson, if you might walk us through these.
Not at all. The image on the left on the first slide demonstrates an area of an asymmetry. The term asymmetry usually refers to it being seen on one view only. I don't have the second view. Interestingly, it's a focal asymmetry if you see it on two views, which intellectually makes no sense to me, but that's how it's defined. And then you can see the images from the ultrasound, and there is a hypoechoic, round, slightly parallel mass with a lot of posterior shadowing, which suggests that that it's highly likely to be malignant. On the images that I have, I can't say anything about what the lymph nodes look like on imaging, not to say that that's 100% one way or the other, but whether or not there was an abnormal node imaging wise that could be actually biopsied or not in a situation like this, I can't answer. But that's something that somebody could also look at if they felt that they needed to sample a lymph node at this point.
Perfect. Thank you for that. So Dr. Woolmark, can you comment for us sort of how often is this something that happens, this sort of failed mapping, and how would you approach this particular patient?
Well, failed mapping certainly happens when we started B32, which eventually randomized 5,000 patients to sentinel node versus axillary node dissection. There was a learning curve. And we had interventions where we had individuals visit various institutions to review the methodology relative to sentinel lymph node resections, and that goes up. But even in skilled hands, there's about 5 to 7% failure rate to identify a node using both methylene blue and technetium, which was utilized in this instance. So what does one do? I think the first question ought to be, why are we only given the choice of high dose lymphoscintigraphy or an axillary lymph node dissection? Granted that it's the standard of care to do an axillary lymph node dissection if you don't do a sentinel node. But knowing what we know today, I would want to try modality imaging of the axilla. If it's negative, I would then ask for an Oncotype or a mammoprint. We know we've just had the data from our exponder. Even if this individual had 3 positive nodes and is postmenopausal, it would not influence how we treat the patient. We would not utilize chemotherapy.
So why do anything? And why do a sentinel node at all in this patient?
Maxine, that's what I'm leading up to. I'm trying to create a crescendo.
Sorry, okay.
which obviously has now been sidetracked.
I'm so sorry. I will never do it again.
Why do anything? Precisely. I would, if trimodality imaging were negative, and this patient had an Oncotype of under 25, I would do nothing. Clearly, as Maxine anticipated, I would do nothing. So I think that's a perfectly reasonable approach. And if I and I've been there intraoperatively and not found a sentinel node with lymphoscintigraphy, then I do a low level 1. I wouldn't call it a resection, removal. Many years ago, we analyzed the data from the NSABP, and I published a paper that I've forgotten until this moment. That 5 lymph nodes removed it gives you a great deal of information. It's certainly very good in assessing whether the axilla is positive or negative. So intraoperatively, during the first procedure, if the sentinel node is a failed intervention, then I remove some level 1 lymph nodes and have those analyzed. And if they're negative, and I usually do have trimodality imaging preoperatively, with that, I'm comfortable in leaving it at that. And in this particular case, I think doing nothing is a very reasonable option. And from my perspective, would be the number 1 option, given the prerequisites that we defined, namely negative trimodality imaging and an Oncotype of under 25.
So let me ask another question now that I've ruined your crescendo. Why do trimodality imaging? I mean, seriously, if you did ultrasound imaging and you didn't see a lot of abnormal nodes, so one of them may be positive, but you don't really care so much, why not just stop at that?
I could be convinced to do that.
Good.
I would certainly listen to your sage input, even crescendo or no crescendo.
I'm so pleased. We should start working together.
That would be a lot of fun.
Okay, just because I don't want Dr. Vicini to be left out of this great conversation, Dr. Vicini, would you, if you, let's say that Dr. Woolmark,
where you're going with this.
Yeah, let's say Dr. Woolmark decided to, see, now you're taking my crescendo. Let's say Dr. Woolmark decided not to do anything here, that the Oncotype was, 12, and he decided not to do any further surgery. Would that change how you would approach your radiation in the adjuvant setting?
Well, actually, no matter what, you're going to be doing something with the radiation, right? It's a lumpectomy, and so we're going to, unless we're doing partial breast irradiation, we're going to include some levels of the axilla. The question is, how much do we extend it? And, I would imagine about half the radiation oncologists in this country, given the scenario where you can't map things out accurately, would probably use what are called high tangents, right? Where you bring the upper border of the radiation field just below the humeral head. But you still
we used to call that radiotherapy creep. I mean,
it is. It's exactly correct.
Not referring to the radiotherapist, but the methodology.
The problem with doing that is you don't know how much of the level of the axilla that you're actually including, right? But nonetheless, you do modify your fields a little bit depending upon what was done in the axilla, obviously. So given if you weren't able to map and we were given this scenario, we would look at what is the risk that they actually could be some axillary nodes, and we would give a little bit of the radiotherapy creep upward, to quote Norm.
All right, I appreciate everyone. So really this is, a case where the multidisciplinary input, looking at the potential at the genomic assay here, the Oncotype is really sometimes can be informative, as everyone has kind of pointed out, because it really would take, a very high score to change, to make the identification of 1 or 2 or 3 lymph nodes here really change this woman's therapy. So what we would recommend for this particular patient is, after careful imaging, making sure that there was a clinically negative axilla with really good quality imaging, that the preference would be to do nothing here in terms of additional surgery, or to consider try another attempt at sentinel lymph node biopsy, or just sort of a limited resection. And then we would move forward with standard adjuvant radiation therapy, with sort of encouragement of high tangents or radiation creep if nothing else was done in terms of additional nodal assessment.